Primary alveolar proteiniosis (PAP), pathophysiology and clinical features. Pulmonary alveolar proteinosis, also referred to as alveolar lipoproteinosis, which is a rare alveolar filling defect affecting around 3 per million people. There is limited published literature, 5 reported cases series of more than 10 cases, and only 410 total cases reported. The pathophysiology. The PAB is due to failure of alveolar macrophage to clear spent surfactant, leading to the filling of alveoli with a phospholipid proteinaceous material. It's thought that the defect has autoimmune basis and in the idiopathic form is due to presence of antibodies to granulocyte macrophage colony stimulating factor GMCCF, which cause inhibition of normal alveolar macrophage function, leading to abnormalities of surfactant homeostasis. Effects in GM-CSF signaling have been identified in animal models, and the congenital disease is thought to be due to mutations in surfactant gene proteins. Other mechanisms for surfactant accumulation have also been identified and include the following. Heavy dust exposure leads to surfactant hypersecretion, which exceeds the lungs' normal clearance mechanism. Animal models have shown that this condition develops from endogenous lipoid pneumonia with the accumulation of lipid-laden macrophages, which break down to release surfactant. Amphiphilic drugs as amiodarone and chlorpheniramine, lymphoma, leukemia, and immunosuppression. The mechanism is uncertain, but it is thought that the lipoprotein may be generated from degenerating alveolar cells. Appearances similar to alveolar lipoproteinosis may also be seen in endogenous lipoid pneumonia resulting from bronchial obstruction and are described in surfactant secreting alveolar cell carcinoma. Histology. The alveoli are filled with a granular cellular eosinophilic periodic acid escape positive deposit. Cholesterol clefts and large foamy macrophages may also be seen. The alveolar architecture is usually well preserved, and surfactant protein can be identified using immunohistochemistry, and electron microscopy shows multiple eosinophilic bodies consistent with denaturated surfactant. Epidemiology presents aged 30 to 50 year. Case reports in children and elderly. Male to female ratio is 4 to 1. Increased incidence in smokers and rare familial cases reported. Clinical features typically presents with breathlessness and a non-productive cough. Examination may be normal, or crackles may be heard on auscultation, and the clubbing in one-third. May present with superadded infection causing an apparent acute onset of symptoms in association with fever, and the median duration of symptoms before diagnosis is 7 months. Opportunistic infection is the major complication, most commonly nocardia species, fungi, and mycobacteria, and this occurs due to impaired macrophage function and impaired host defense due to surfactant accumulation. Diagnosis. It's usually made on the basis of characteristic CT appearance, although other tests may be useful. There are also raised serum LDH, and arterial blood gases shows hypoxia and increased AA gradient. Pulmonary function tests reveal restrictive defect with reduced lung volume and transfer factor. Chest X-rays, there is bilateral consolidation with thickened interlobular septa, usually bilateral. The pattern is very variable and in up to 50% may be perihilar, let's say bat wing appearance. CT appearance is characteristic with airspace shadowing in the geographical distribution, alternating with area of normal lung, the crazy paving pattern. This CT appearance is not specific to alveolar proteinosis, as it is also seen in lipoid pneumonia and bronchoalveolar cell carcinoma. The bronchoalveolar lavage reveals milky washings, identification of antibodies to glomerular basement to the granulocyte macrophage colony, colony stimulating factor, granulocyte macrophage colony stimulating factor, GMCSF. Identification of GMCSF in the identification of antibodies to GMCSF in the bronchoalveolar lavage washing is diagnostic. Again, bronchoalveolar lavage reveals milky washings and identification of antibodies to granulocyte macrophage colony stimulating factor in the bowel washings is diagnostic. Cytological examination shows a granular extracellular deposit with foamy macrophages and cellular debris. The transbronchial open biopsies when CT is not characteristic. Treatment of a choice. Repeated therapeutic whole lung lavage should be performed at a specialist center. There are no randomized controlled trials of this treatment, but there is evidence of efficacy in terms of subsequent improvement of symptoms, physiology, and radiology. The indication of whole lung lavage is usually breathlessness, limiting activities of daily living, and the procedure is done under general anesthesia using 100% oxygen and one lung ventilation using a double lumen tube. Repeated warm saline lavage using a closed circuit continues until the bronchial washing returns are clear. This may take up to 40-liter lavage, and one or both lungs may be treated at a time. The response is variable. Some patients need only one treatment, others may need multiple treatments, and about 10% fail to respond. May be done on bypass or if the patient is very hypoxic. Characteristic milky lavage fluid is obtained. Inhaled recombinant granulocyte colony stimulating factor is a novel treatment option. Small two small 2019 randomized controlled trials which may prevent progression of the disease and improve oxygenation. There is no benefit from treatment with steroids and they may exacerbate opportunistic infections. The prognosis of PAP with whole lung lavage is generally good. Spontaneous remission occurs in one third remains stable, and one third progress to respiratory failure and death. There are reports of progression to pulmonary fibrosis, which may be a coincidental occurrence.